All right, on this episode, we're going to discuss diagnosing fascicular blocks on the ECG and talk just a little bit about their clinical implications. Okay, so everybody's favorite part, we got to go over anatomy real quick. So just to review, so we're all on the same page. The left bundle branch is split into two fascicles. You have the left posterior fascicle and the left anterior fascicle, and each of these are responsible for innervating the left ventricle. The anterior fascicle hits the anterior wall and travels downward inferior, and the left posterior fascicle wraps around and gets the left lateral wall. And that's important when we talk about when they block, because the ECG presentation is going to be completely based on that concept. So basically upward and leftward flow in the left ventricle is driven by the posterior fascicle, and downward flow, inferior flow, is innervated by the anterior fascicle. So because of that, anytime we have blockade over one of the other, then you're going to get a deviation on the ECG. And so you're going to notice a vertical axis deviation with the left anterior fascicular block, because that posterior fascicle directs flow leftward. You're going to get a left axis deviation, and the opposite with our other one. So if you don't know cardiac axis, I'm not going to go into it in this video, but I have a link here to another YouTube video I have, which is the basics for determining cardiac axis on the EKG. All right, so left anterior fascicular block. So as I said, you can see here on my little drawing, we have the anterior fascicle is blocked. So if the anterior fascicle is responsible for that downward and anterior flow, it directs all the flow of the left ventricle leftward, and so that's going to give us a left axis deviation. Now, anterior fascicular blocks are way more common than the left posterior fascicular block. You actually, once you learn how to identify these, you're going to notice that a lot of your left axis deviated patients have a anterior fascicular block. It's the filament is very thin and easily diseased from ischemia or prior injury patterns. The posterior fascicular blocks are much more rare because they have a more robust anatomy comparative. So what do we look for? So on the left anterior fascicular block, you have a left axis. So again, to review, real quick, down and dirty, easy way to identify a left axis on the ECG, you look at your 6 x-axial leads, which are on your screen here, 1, 2, 3, AVR, AVL, AVF. If I have a left axis, the QRS complex is going to be the most positive, the most upright, is going to be AVL. So AVL stands for augmented vector left, so that's indicating our flow is moving to the left. Now, one difference between this and just a true left axis deviation is that you're going to have a little Q wave into that R wave. So to review, Q is the first downward deflection, R is the first upright deflection. And so you have a QR wave that has to be present in 1 and AVL, and then you have to have the complete opposite. You have to have the mirror image in all 3 of your inferior leads, 2, AVF, and 3. And so the opposite to a QR wave is a little r, which is that little upward deflection you see in 2, 3, and AVF, followed by that deep S wave. Okay. If you see that pattern, that is the criteria for a left anterior fascicular block. Now, because this is a hemiblock and not a complete bundle block of either bundle branch, your QRS complexes do not have to be wide. As you can see here, these QRS complexes are still narrow, but there is a slight conduction delay that is occurring. And here's a more zoomed out view. So this is a nice classic pattern. Again, you can see in AVL that your QRS complex is the most upright. So we have a left axis deviation. You can note the little Q into the R wave in 1 and AVL, and then the R and S wave in 2, 3, and AVF. And here I've provided arrows. The green show you the QR waves in 1 and AVL, and then the red is indicating the reciprocal change, the RS wave pattern in 2, 3, and AVF. Here's another example here. You can see same exact pattern. You have a left axis. AVL is clearly the most upright, indicating that the general flow of depolarization is moving towards AVL. at negative 30 degrees, and then you have the little Q waves preceding the R waves, and then the opposite in 2, 3, and AVF. You have the R, S pattern in 2, 3, and AVF. You also notice that you have a first degree AV block. That's common in fascicular blocks. As part of the conduction delay, you can have some conduction as the signal's being sent down through from the AV node, and so you'll end up with first degree AV blocks very commonly with these fascicular blocks. And there you can see, I highlighted for you again, the green arrows show the QR waves that you're looking for in 1 in AVL, and then the opposites are S wave in 2, 3 AVF. Okay, so that was left anterior fascicular block. So left posterior fascicular block is just the opposite. So everything you just learned, you just have to flip the criteria, and that's what you're looking for. So you can see on my animation here, that leftward flow is blocked, and so you're going to get a net downward and rightward flow, so an inferior and rightward flow. And so you're going to be looking for a right axis. And in fact, right axis deviation has a very limited number of things that can cause it, and one of those things is a right, for a right axis deviation, is a left posterior fascicular block. So what are we looking for? So same thing, the green represent QR waves. They now need to be present in the inferior. So remember, with the anterior fascicular block, you had the QR waves in 1 in AVL. Now those waves are present in the inferior, which makes sense because the inferior is reciprocal to those high lateral leads. And so you have a QR wave in 2, 3 in AVF, and then in 1 in AVL you have that reciprocal change, that RS wave pattern. Okay, that comes out to a right axis deviation. You can see lead 3, which is the most rightward looking of the hexaxial leads. You can see that QRS complex is the most upright. Now AVR is called augmented vector right, and so some people think that when that is deflected upwards, that's a right axis, but that's actually what we call extreme right axis deviation. Right, AVR sits superior to the heart, and so typically when you have QRS complexes that are completely upright in AVR, aside from limb lead reversal, most of the things that cause that are very abnormal rhythms like VTAC or sodium channel blocker toxicity. Okay, here's a zoomed out view. Here's the whole 12 lead. You can take a look at it. You've clearly got the rightward axis. Lead 3 is your most positive. You have the QR wave. It's a little hard to see, but you have a QR wave in 3 AVF and 2, and then an RS wave in lead 1 in AVL. And there I've zoomed in and shown you what you're looking for. Okay, here's another example. So ignore your precordial leads over there. Kind of look at our hexaxial. That's these 1, 2, 3, AVR, AVL, AVF is how we diagnose these fascicular blocks. And so when we look at this, you see lead 3 is your most upright, giving you a rightward axis. And let's zoom in here. There you go. And so you can see the green represent the QR wave. The Q wave is barely visible in lead 2, but you can see just a little bit. But there is a QR wave pattern with an RS pattern in 1 in AVL. And you can see over in the precordials that we also have a right bundle branch block occurring as well, which I'll talk about that in a minute. With the left posterior fascicular blocks, they're very rare. Remember that filament, the posterior fascicle is a very thick, robust filament, and it takes significant disease to cause it. The majority of the times I've seen it, or the few times I've seen it in my career, has been from extensive myocardial injury, typically acute MI. Severe hyperkalemia and some of the toxidromes can cause it too. But again, this is a rare presentation. If you see it, it should key you in that something is amiss. It's not something to just sweep under the rug. There's something going on here. Okay. And so that brings us to the next thing. So those are all the criteria for finding a single fascicular block, so either the anterior or posterior. Now what happens if you do have, like I showed you on that previous slide, a right bundle branch block with hemi block, either the left anterior or posterior fascicle. And so we term those bifascicular blocks. Now the most common you're going to run into is kind of the same thing. It's a right bundle branch block with a left anterior fascicular block. Both the right bundle and the left anterior fascicle are thin filaments. They're very easily diseased or compressed. In fact, people with significant work of breathing can mechanically compress their right bundle branch block as their pulmonary pressures go up and it causes strain in the RV. Both of those are very thin filaments. They're very easily blocked, and so that's clearly the most common you're going to see. Again, number one criteria is heart disease, and interestingly, a statistically significant percentage of anterior MIs will present with bifascicular blocks. Again, we'll talk about identification with acute MI here in a few slides, and what that would mean to you. Now, if you don't know how to diagnose right bundle branch versus left bundle branch block, you can click on the link at the bottom there. It's a YouTube video I have on how to identify those the standard presentations for both of those. Okay, here's an example. You can see V1 and V6 is how you look for a right bundle branch block. So you're going to see V1 is upright. You have an RSR prime pattern with the R prime wave being bigger. That's classic presentation for right bundle. The QRS is wide. V6 is slightly abnormal for right bundle. V6 should be upright with a slurred S wave, and you can see here it's almost isoelectric and actually almost looks like it might be negative. So there's your right bundle branch block. You come over, and now we got to apply our fascicular block criteria, and so we note a leftward axis, so AVL is the most upright, and you have a QR wave pattern in one in AVL with an RS pattern in the inferior leads. So you have a right bundle with a left anterior fascicular block, or what we call a bifascicular block. You'll also notice that first degree AV conduction delay, which is very common in these presentations. Okay, here's another example. We have a right bundle branch block again. V1 is upright, wide with an RSR prime pattern. You have a V6, which is positive in this one with a slurred S wave. And then so that'll give you the criteria for a right bundle. We look over to the hexaxial leads. We have a left axis with a QR wave in 1 and AVL with an RS wave present in 2, 3 AVF. This is another bifascicular block. Okay. Now, one extra consideration, like I said, kind of going back to that first example, is technically what you will see, a very common presentation with the right bundle and left anterior fascicle block, is that V6 will end up being negative. Now, people trying to overcompensate and trying to sound smart basically will call this an RS ratio greater than 1. I don't know why people use this. Why don't you just say it's positive or negative? If your RS ratio is greater than 1, your QRS is positive. If it's less than 1, it's negative. All they're talking about is comparing the ratio of the two. So how tall is it versus how negative it is? I don't really understand why people do that, other than to try to sound smart and confuse people. So basically, if you see a right bundle branch block pattern, minus the fact that you note V6 to be negative, take a look over on the hexaxials. If you see a left axis, you may have a bifascicular block pattern. That's probably the most common reason that you would see that. If you don't see that, then you may be dealing with like an idioventricular V-tach type rhythm. And then the trifascicular block. So basically, anytime that you have a complete block of that right bundle branch and both of your fascicles, we term that a trifascicular block. Okay, now this type of blockade will also cause a significant AV conduction delay. Again, as I said, that's very common to have at least a first degree, and these you'll often be accompanied by a second degree or a complete AV block. And anytime you see this patient either has a significant cardiac history or is undergoing currently some sort of cardiac event. It should definitely provide pause to the provider to really evaluate your patient and make sure we know what's going on. So here's an example again, very ugly. So this is a right bundle branch block pattern. You can see that V1 is upright, RSR prime pattern, R prime being the largest. You have the slurred S wave in V6 with an overall positive QRS complex. You look over to your hexaxial leads, and you have a QR pattern in 1 in AVL, although again, kind of difficult to see. And then 2, 3 in AVF have that RS pattern, although again in 2 and AVF and 2 that is very difficult to see. Now, this patient clearly has significant cardiac disease, and then we can see all these P waves that seem to not be communicating with the ventricles. So your PR interval is changing beat to beat, and so this is a complete or third degree AV block as well. And so the right bundle branch plus the left anterior fascicle plus third degree AV block indicates that we have a trifascicular block present. Okay, and lastly, so anybody who's heard me talk about ECGs knows my opinion on using things like new onset versus old left bundle branch blocks for determining acute MI. It's 2020. We need to get away from that. The Scarbosa criteria has been around for a long time. It's well evidenced. It's completely unnecessary, and that Scarbosa criteria can be applied not just to left bundles, but these fascicular blocks. So again, if you do see a fascicular block that presents as new onset, it should certainly give you caution, but it is not grounds alone for activation. Now, if you want to know a little bit more about Scarbosa criteria and my take on it, I have a very easy, simplified algorithm for it, and you can just click the link here, and I have a nice little 20-minute YouTube video on how to use Scarbosa criteria in the acute MI. All right, thanks guys for listening, and I'll see you on the next one.